In ophthalmology, today we will be discussing about cornea, lens, and cataract, retina. These three topics in opthal is going to be a vital, very important topic. Surely, a image-based question is going to come up in cornea, and the question from diabetic retinopathy or hypertensive retinopathy question is also going to be coming. This can give you easily 1 to 2 mark in exam. Please don't lose that. The person who gets 148 or 149 in FMGE exams know the pain of the 1 mark. So please concentrate on images in cornea and these topics in retina. So cornea, we'll start with cornea. We will discuss about cornea and then we will go to the images today. First, the lens of cornea. To in Bowman stroma. Stroma is the thickest layer, occupies about 90% of the cornea. Then we have Descemet's membrane. And last, innermost endothelium. Corneal scarring or opacity in the cornea results due to a damage to the second layer, that is Bowman's membrane. And this Bowman's membrane cannot regenerate. This point cannot regenerate. Descemet's membrane is innermost, so bacterial parasitic infection virus cannot enter than these Descemet's membrane to the endothelium except for one organism, that is fungus. Fungus can penetrate into the intact Descemet's membrane. Only fungal infections can penetrate intact Descemet's membrane. Endothelium, the innermost layer, endothelium is the most important layer responsible for the transparency of the cornea. It is the most important layer responsible for corneal transparency. This is a single layer made up of cells. A single layer of cells. We have endothelial pump. There are endothelial pumps present in this endothelial layer. These pumps out the aqueous humor and keep the endothelium or cornea dry. If there is any damage to endothelium, it will lead to a irreversible corneal edema as the aqueous humor gets inside. So there is corneal edema. The endothelial cells present here are counted with the help of a peculiar important microscope called as specular microscope. Specular or microscopy or specular microscope. So this is about a few points about anatomy of the cornea. We'll move on to the most important topic, corneal ulcers. Corneal ulcer, sure shot, one question will be coming. One question, either as an image-based question or as a theory question, but surely you will get a question from corneal ulcer. They have asked question showing a viral keratitis and asking what type of viral keratitis it is. Is it or acanthamoeba ulcer? They have asked presentation clinically injured by a tail of a buffalo or a cow or injured by a plant, and what type of presentation they have shown, given us the pain, there is congestion, and what type of ulcer is it. So they have asked questions clinically and also as a image based question. So we'll start with corneal ulcer. Corneal ulcers, there is a breaks in corneal epithelium with the death of underlying cells. Death of underlying cells. There is formation of hypopyon. It is due to accumulation of WBC, white blood cells, since it's the first line of defense. Earliest symptom of a corneal ulcer, photophobia, sensitivity to the light. Pain is the most important symptom. There is extreme pain here, It's extremely painful since there is a lot of nerve endings present in the cornea. Next, we move on to the specific types of ulcer. Predisposing factors. So predisposing factors for acanthamoeba ulcer is contact lens users, the important point here is most common organism attacking contact lens users is going to be Pseudomonas, more common than acanthamoeba. So the most common cause of corneal ulcer in a contact lens user is going to be Pseudomonas, not acanthamoeba, and the ulcer is going to be a ring-shaped ulcer or circular ulcer. Forms there is pseudodendrites, and there is going to be extreme pain here that is out of proportion to the presentation. Then we have bacterial keratitis. Most common cause worldwide is going to be Staph aureus, and the most common cause in India is going to be Streptococcus pneumoniae or pneumococcus. Ulcer serpens or hypopyon in a corneal ulcer is mainly going to be a pneumococcal ulcer. Ulcer serpens is something that you have a corneal ulcer, and serpens is meaning snake, shape of a snake, and hypopyon previously we discussed made up of WBC, so it's going to be a pus. You have ulcer here, for example, the ulcer will look like a snake, and you will have a hypopyon, pus in a bacterial ulcer. Predisposing factors. Foreign body in eye trauma. Predisposing factors are important because they will give you the clue to get the answer. For example, they are giving you a image of a ring-shaped ulcer, and in the question they will give you it is a the previously the patient was using a contact lens, and he or she used tap water to clean those contact lenses. So you can get the answer as acanthamoeba, that is ring-shaped ulcer is present given on the image, and the clue given as contact lens user. If there is a if they are asking you the most common cause of ulcer in a contact lens user, the user is going to be Pseudomonas. But if they are asking, giving you an image, please go for acanthamoeba if there is a ring-shaped ulcer. Bacteria that penetrates intact corneal epithelium are: number one, Cornebacterium; Gonococci; Meningococcus; Haemophilus; Listeria; and Shigella. Then we move on to fungal keratitis. In fungal keratitis, usually there is more symptoms. There are more signs than symptoms. Causes of fungal keratitis are Aspergillus, and Fusarium. Usually it is a slow growing ulcer. Predisposing factors: prolonged use of topical steroids. Topical steroid use is going to decrease your immunity. It is a immune suppressor, and the fungus is going to grow. And the second one, organic matter injury. It can be a vegetable injury, a plant injury, or a tail of a cow. So any organic matter injury. This is a predisposing factor for a fungal keratitis or fungal ulcer. And the image is going to give you a finger-like projections, feathery margins, and satellite lesions. Word satellite lesion is important here. They have asked the question just as a one-liner. Satellite lesions are seen in which type of ulcer? We have then viral keratitis, Viral keratitis is most commonly caused by the virus HSV or herpes simplex virus. There is epithelial keratitis, stromal keratitis, epithelial keratitis. We have the important question: dendritic ulcer. In dendritic ulcer, there is loss of corneal sensation, and this dendritic ulcer can lead to complicate to a geographical ulcer. Dendritic name says dendrites. So in a nerve, you can see a lot of hair-like structures, dendrites. Same as just like that. In the eye, you can you are going to get a lot of dendrites. So that's why we call it as a dendritic ulcer. We're getting a shape of the dendrite, hence the name. Then we have neuro paralytic keratitis seen in seventh cranial nerve palsy. Because of the seventh cranial nerve or the facial nerve supply the orbicularis, a muscle that is important for closing of eye. If there is injury to this facial nerve, eye cannot close. Since orbicularis is the muscle that is used for closing of the eye, it controls our eyelids. If there is no closing of the eye is going to get exposed to everything. If there is a dust, as a reflex, we are going to close our cornea using our eyelashes. But here, since there is seventh nerve palsy, there is going to be no function of the orbicularis, so there is no closing of the eye. This will lead to exposure keratitis. We also have neurotropic keratitis. Neuroparalytic keratitis is due to seventh cranial nerve palsy. Neurotropic keratitis is going to be the trigeminal fifth cranial nerve palsy. The fifth cranial nerve carries corneal sensations. If there is a cranial nerve of 5 getting paralytic, then it will lead to poor corneal sensation. So the foreign body can lodge in cornea and irritate foreign body. on cornea causes the ulcer. And last we have herpes zoster. We discussed herpes zoster during our dermatology class. Herpes zoster has shingles. Herpes zoster is caused by varicella zoster, causes chicken pox. This chicken pox will settle down, but it can reactivate from a dormant or a sleep state during. Can anyone tell me during which time it can reactivate from dormant state during? Yes. During immunocompromised state, there is zoster infection in young patients. It is a sign of HIV infection. And we have our important rule, Hutchinson's rule. This rule is useful to predict the herpes zoster ophthalmicus. It is the rule is wherever the nerve goes, the virus follows the nerve. Wherever the nerve goes, the virus follows. This is Hutchinson's rule. A vesicle on tip of the nose indicates infection to the eye too, because both the tip of our nose and the eye cornea are supplied by the same branch of. Yes, anyone? Can anyone tell me the nerve? Name of the nerve? Yes. Can tell in the chat box too. Branch of nasociliary nerve. We move on to the treatment of corneal ulcers. Bacterial, topical, fluoroquinolones are used. are the drug of choice like moxifloxacin or gatifloxacin. In case of fungal corneal ulcer, drug of choice topical natamycin, viral topical acyclovir, and acanthamoeba PHMB, that is polybexamethylene biguanide, to manage the pain. We use cycloplegics, cyclociliary plegic paralysis. So we are going to paralyze the ciliary muscle and the ciliary nerve. Since ciliary nerves are the one that's going to increase the pain, or pain are the one that's going to carry the pain sensation from the cornea. So we're going to paralyze that with the help of homatropine or atropine. If there is perforation, management is going to be perforation of the cornea. The management is going to be a reconstruction with keratoplasty. So we'll look at the images as for. We'll have a short summary. So cornea, we have 5 layers from outer to inner: epithelium, basement membrane, Bowman's membrane, stroma, Descemet's membrane, and endothelium. Corneal scarring or opacity is due to a damage to the second layer, that is the Bowman's membrane, and this Bowman's membrane cannot regenerate. Descemet's membrane is the only penetrated by fungus or a fungal infection. Endothelium is important to maintain the dryness of cornea. If there is any damage to the endothelium, we are going to get a corneal edema and it's going to be irreversible. Earliest symptom of corneal ulcer is going to be a photophobia. Pain is the most important symptom and it's going to be extremely painful because of the extensive presence of nerves in the cornea. Acanthamoeba ulcer, predisposing factor is going to be a contact lens user, and the most common cause of ulcer in a contact lens user is going to be pseudomonas, most common than with acanthamoeba. It's going to be a ring-shaped ulcer, and bacterial keratitis, most common causes worldwide is going to be Staph aureus, and the most common cause in India is going to be pneumococci. Predisposing factors for a bacteria or for a bacterial ulcer is going to be foreign body in the eye or a trauma. Fungal keratitis, usually there is no symptoms in fungal keratitis. That we are going to get a lot of signs than with the symptoms. Usually, the patient will present with no symptoms. Only the sign are going to be seen by a doctor. And the causes for a fungal keratitis is going to be Aspergillus and Fusarium. Usually, the fungal keratitis is going to be a slow growing one. So, question we will get as a patient with a trauma to the eye by a vegetative lesion, vegetative matter, and it has been since 3 to 4 weeks. So it's a slow growing 3 to 4 weeks, and there is no symptoms. It's going to be a fungal keratitis. Whereas fungal keratitis, viral or a bacterial ulcer, going to or a parenchymal ulcer is going to be painful, and it's going to be present to you in 1 or 2 days, as it is, there is a lot of pain. Predisposing factor is going to be prolonged topical steroids, organic matter injury, finger-like projections will be there, feathery margin, satellite lesions are seen in fungal. Then we go for viral, caused by HSV, herpes simplex virus. Epithelial keratitis, we have dendritic ulcer, and they fuse together to form a geographical ulcer. Neuroparalytic keratitis is going to be seen with due to 7th cranial nerve palsy, and the neurotropic keratitis is going to be due to 5th cranial nerve palsy. Herpes zoster or shingles caused by varicella zoster, causes chicken pox. The chicken pox reactivates from dormant state or a sleeping state due to immunocompromised state, and a zoster infection in young adults is due to going to be a sign of HIV infection. Hutchinson's rule: wherever the nerve goes, the virus follows. So if there is a vesicle found in the neck, nose, tip of the nose, and it's going to indicate there is an infection of the eye too, since because the tip of the nose is going to be supplied by the same nerve that supplies the cornea, and the nerve is mesociliary nerve. Treatment of corneal ulcers in case of bacteria is going to be topical fluoroquinolone, moxifloxacin, fungal topical matamycin, the drug of choice, viral topical acyclovir, acanthamoeba, polyhexamethylene biguanide, and to manage the pain, fomatropine, atropine, and if there is a perforation, keratoplasty. We'll look at the images. So this is our specular microscopy, with which endothelium is viewed. This is a normal endothelium. This is our acanthamoebal ulcer. You can see a ring shape. This is a ring-shaped ulcer, and it is also a perineural keratitis. Outer part of the cornea is mainly infected. This is acanthamoebal ulcer. This is our Hutchinson's rule: herpes zoster ophthalmicals. First, initially there will be a infection to the tip of the nose, and the nerve is going to followed by the virus, and it's going to end up in our cornea. So wherever the nerve goes, the virus follows. This is Hutchinson's rule. This herpes zoster ophthalmicus, and the nerve involvement is going to be nasociliary nerve. This is a very important image. Herpes zoster, herpetic keratitis caused by herpes simplex virus, and you can see the dendrites here. This image has been asked more than 2 to 3 times in the recent FMGE exams. Please keep in mind this image, very, very important. A greenish ulcer. Background, we have a blue colored cornea. This image is a very, very important image. Herpetic dendritic keratitis. They're just going to give you the image and going to give you the 4 types of the ulcers: fungal, corneal, viral, acanthamoeba. So easily you can identify it as a viral or a herpetic keratitis. This is our fungal keratitis, feathery margins, and there is a hypopyon fixed. So this is a feathery margin. This is fungal keratitis. Usually, the fungal keratitis is going to be present with no symptoms. See, you can see the eye is there is congestion here, redishness is there, but the patient is not going to complain you any pain. So there is more signs than with the symptoms in fungal keratitis. So we will move on. We'll move on to retina. In retina, most important topic is diabetic retinopathy. Most common cause is going to be our diabetes mellitus. Risk factors, duration of diabetes going to be the most important prognostic factor. If there is a poor control of blood glucose, if there is a comorbid hypertension with diabetes and pregnancy, timing for checkup, if there is type 1 diabetes mellitus, 5 years from detection, and type 2 diabetes, immediately it should be checked. This is insulin dependent, non-insulin dependent. After that, once every year for both of the types. Clinical features, symptoms is going to be blurred vision, floaters, fluctuation in vision, and impaired color vision. Signs important. Signs are important. Earliest manifestation is going to be microaneurysm. Hallmark is going to be the neovascularization. Patho, there is occlusion, and there is leakage. The occlusion is going to be due to thromboembolisms. Thromboembolisms. So there is a occlusion leading to hypoxia. There is our VEGF, and this VEGF is going to growth factor for vascularization, leading to neovascularization. Thromboembolisms usually does not occur in a person without any diabetes. Thromboembolisms are more common in diabetics, more than 5 to 6 times common in diabetics than in the normal people. And easily you can, obviously you know that myocardial infarction, heart attacks are more common in diabetics than in the normal people, and it's because of this thromboembolisms in the heart. And then the leakage is due to the necrosis of the pericytes. The embolism is going to cause the pressure. There is ballooning out of the microvascular vessels, going to lead to aneurysms, which is the ballooning out, and this aneurysm is going to leak. There is leakage. So this is the pathology of diabetic retinopathy. Classification. We have NPDR and PDR. NPDR, non-proliferative diabetic retinopathy, and proliferative retinopathy. NPDR, non-proliferative diabetic retinopathy. There is microaneurysms. Previously, we discussed how this microaneurysm happens. It's the earliest manifestation. It's going to be a hemorrhages. Looks like a dot and blot hemorrhages. There's going to be hard and soft exudates. These hard exudates are the lipid deposits on retina. Since there is a leakage, we are going to see a leakage of the proteins or lipids, and these hard exudates are going to be due to the lipid deposits on retina due to the leakage. And we have our soft exudates due to the occlusion, mainly made up of proteins. Then second we have our proliferative diabetic retinopathy. In proliferative diabetic retinopathy, that is proliferation. So neovascularization is going to be seen here. We have NVD and NVE. NVD is neovascularization of the disc. NVE is neovascularization elsewhere. So the visual loss in diabetic retinopathy is due to, in case of a non-proliferative diabetic retinopathy, it is due to the macular edema and in proliferative diabetic retinopathy is going to be due to vitreous hemorrhage or a retinal detachment, and the type is going to be tractional retinal detachment. And third is going to be our neovascularization leading to neovascular glaucoma. Coming to the treatment. Treatment of diabetic retinopathy. In case of a non-proliferative diabetic retinopathy, we should treat the macular edema by laser photocoagulation. The laser here is going to be a double frequency ND-YAG laser. It is a green laser and applied peripherally. And this laser is going to give you heat, and this heat used to absorb the edema. So we have learned that in non-proliferative diabetic retinopathy, macular edema is going to cause the vision loss. So main line of management is going to be first line, and the main line is going to be laser photocoagulation to absorb the edema. Next to laser, we have drugs, that is anti-VEGF. This anti-VEGF is used not to complicate the non-proliferative to a proliferative, because we learned that VEGF, vascular endothelial growth factor, is the one that's going to cause our neovascularization. So neovascularization is proliferation. So to not to complicate the non-proliferative to a proliferative one, we are going to use this anti-VEGF drug, that is Bevacizumab monoclonal antibody. and ranibizumab can also use intravitreal steroids like triamcinolone acetonide. The treatment for proliferative is going to be retinal photocoagulation. Here we are going to focus on the leakage to seal the blood vessels. We also have panretinal photocoagulation and we are going to coagulate the entire retina except for macula. If you are going to coagulate the entire retina with a laser, we will eliminate the hypoxia. Hypoxia will not happen. If there is no hypoxia, neovascularization will not happen. If we use retinal photocoagulation, which uses focal laser, we are going to get a recurrence again and again. But here, recurrence is not common. So panretinal is best preferred to treat a proliferative diabetic retinopathy. So this is about diabetic retinopathy. Next we move on to next we'll go for CRVO. Central retinal venous occlusion. Causes for CRVO are older people. There is uncontrolled hypertension and uncontrolled diabetes. Patho, how this occlusion is being created. Usually the central retinal artery, the main artery that supplies the retina, and the vein, central retinal vein, main veins to drain the blood from the retina, both share a common adventitious sheath. If there is a thickening of this artery, it can compress retinal vein in the common adventitious sheath area. And the CRVO causes sudden, painless loss of vision, we on examination, the entire retina is full of a flame-shaped hemorrhage. Is what do you call this appearance? Anyone? Can anyone tell me? What is the name of this appearance? Very important. Tomato ketchup. Splash tomato. Blood under fundus is going to be seen. There are soft exudates seen here also. The veins are dilated and tortuous, tensed. Disc edema is also seen here. In CRVO, because of the occlusion of the vein and because of the occlusion is due to the artery, and there is a lot of hemorrhages that is happening. That is our flame-shaped hemorrhages being happening. There is going to be a hypoxia, and if there is hypoxia, comes our VEGF, vascular endothelial growth factor is going to think that there is hypoxia, and we should increase the vascularization newly, and that is called as our neovascularization. And if there is neovascularization, it will cause a important glaucoma called as neovascular glaucoma, and the glaucoma that is caused due to CRVO is called as 90-day or a 100-day glaucoma, because it takes 100 days to develop a glaucoma here. Most common cause of vision is going to be a macular edema, just like NPDR. And the treatment is going to be control of BP, sugar, control intraocular pressure with anti-glaucoma drugs, Macular edema is treated with intravitreal anti-VEGF and steroids. And the neovascular glaucoma is also treated with the anti-VEGF drugs. Our bevacizumab, ranibizumab. The drugs are important in ophthalmology is concerned. When we move on to CRAO, central retinal artery occlusion. The risk factor is same. Older people, uncontrolled hypertension or diabetes, and pathogenesis is going to be corroded atherosclerosis. Because of this atherosclerosis, the embolus is going to lodge into the retinal artery and it's going to occlude the artery. So that is the term central retinal artery occlusion. This occlusion is due to the embolus that is coming from the carotid area. Clinical feature: sudden, painless loss of vision, and on examination we can see cherry red spot from the foveal area surrounded by a white retina. There is cattle truck appearance or a box car appearance. This is because of the discontinuity in the blood columns or in the artery. Treatment for CRAO is going to be ocular massage. Since it's due to the embolus, this massage can move the embolus out of the artery. So ocular massage. If there is a immediate high intraocular pressure, we should lower it with the help of drugs like immediate lowering of intraocular pressure by mannitol, acetazolamide. What is mannitol? What drug it is? Where is it used mainly? Mannitol pharmacology. Mannitol is a osmotic diuretic. What about acetazolamide? What drug is it? Anyone? It's a carbonic anhydrase inhibitor. Next we have cystoid macular edema. The macula gets edematous, causes slow, painless loss of vision, causes of CME or CME, diabetes, uveitis, mainly pars planitis, retinitis, pigmentosa, Irvine gas syndrome. It is CME after a cataract surgery. Can also be due to CRVO, nicotinic acid, or post surgery of the eye. More common cause is going to be diabetes. Clinical feature: slow, painless loss of vision, there is metamorphopsia. Metamorphopsia means distortion of shape when seen. This metamorphopsia occurs in all type of macular disorders, forms. We have two: micropsia objects appear as small and distorted, and macropsia, where the objects are large and distorted. The diagnosis is made with the help of Amsler's grid. Name is important. Investigations used: fluorescent angiography and optical coherence tomography, angio of eye, dyes used, fluorescence used, angiography is used for retina, and ICG for choroid. ICG is indocyanine green. OCT is the gold standard investigation for all macular disorders, and the treatment of cystoid macular edema is going to be topical steroids, topical NSAIDs like mepafinac, and steroids like triamcinolone used as a subtenon injection. So this is CME. Then we have CSR, central serous retinopathy. It is we have fluid collected both in CSR and the CME. The difference between CSR and CME. In CSR, the edema is going to be present between the neurosensory layer of the retina and retinal pigment epithelium. Whereas in CME, the edema is going to be present in the outer plexiform layer of retina. And fluorescent angiography shows ink blots and smoke stacks. If this is seen, it is a confirmation. Confirm it is CSR. This question has been asked in exam. In plot, smokestack appearance is seen in. So it is seen in CSR, and the treatment is going to be usually they recover spontaneously, supportive therapy, reassurance, anxiolytics, or a placebo. Anxiolytics are used because CSR mainly happens in type A personality, or a person who's having a lot of stress or tension. And most commonly it happens in males. Not the stress in life. The CSR most commonly happens in males. So next we'll move on to the very important topic, retinitis pigmentosa. So the risk factor is going to be consanguineous marriage, as RP or retinitis pigmentosa is a hereditary condition. The clinical feature, nyctalopia, night vision loss, and ring scotoma. And this nyctalopia progress to tubular vision or tunnel vision. On examination, we are going to have a triad, of pale, waxy, disc. There is going to be arteriolar attenuation, and there is bony specular pigmentation This bony specule pigmentation is the characteristic of retinitis pigmentosa, and investigation gold standard for diagnosing retinitis pigmentosa is going to be ERG, electroretinogram. The treatment of retinitis pigmentosa is going to be 15,000 international units per day of vitamin A. This is not going to be toxic. 15,000 is not toxic and can be teratogenic, so cannot be given during pregnancy. This vitamin A is not going to, does not cure retinitis pigmentosa, but it can help retain vision. For few years. Some syndromes that have retinitis pigmentosa as manifestations are important. Syndromes Basin Conswick syndrome, Lawrence Moon-Brittle syndrome, Usher syndrome, Refsum syndrome. Give me 2 minutes, guys. I'm getting call on my hospital. Basin Conswick syndrome, Lawrence Moon-Brittle syndrome, Usher syndrome, and Refsum disease. Last, we have hypertensive retinopathy. Occurs due to blood pressure of more than 140 systolic and 90 diastolic millimeter mercury. Components of hypertensive retinopathy are there is retinopathy, choroidopathy, inflammation of the choroids and damage to nerves, neuropathy. Retinopathy or damage to retina is going to be acutely due to vasospasm, and chronic is going to be due to the arteriosclerosis. Classification: we have modified keys classification, very important. The name has been asked. We have something called as AV crossings, arteriovenous crossings. Most of the time, arteries cross veins or cross over the veins about 75%, but 25% veins cross over the arteries. In hypertension, there is arteriosclerosis, and this compresses the veins too. There is compression of veins too in hypertensive retinopathy. We have some focal signs of grade 2 of our classification, modified Keys-Cal's classification. This has been asked: gun sign, Bonnet sign, Salas sign, what is accelerated hypertension? Hypertension that leads to end organ damage. What is the term? This is a medicine question. Malignant hypertension, accelerated hypertension with disc changes as disc edema is going to be malignant hypertension. So this is with retina. So we'll look at the images. So this is proliferative diabetic retinopathy. We can see abnormal vessels growing here, and there is a lot of proliferations here. So this is proliferative diabetic retinopathy. Here we can see retinitis pigmentosa, the triad. There is bony spicules, the spots here, blackish spots here, and the vessels you can see here shortened, thin or attenuated vessels, and the disc appears pale. Just with this dark spots you can identify easily, because these dark spots will not be seen in any other disease other than retinitis pigmentosa. So we can identify retinitis pigmentosa with this bony spicules. This is our hypertensive retinopathy. So as you can see, AV crossing here. There is attenuation here also, and we have something called as cotton wool spots in hypertensive retinopathy. That is because of the soft exudate in hypertensive retinopathy. Here also you can see the cotton wool spots and the exudates here. Disc is getting edematous. Arterial or narrowing. There is hemorrhages, AV nicking, that is the artery which is sclerotic is congesting the vein here, and there is copper wiring in hypertensive retinopathy. Here it is the petaloid appearance or flower shaped appearance of CME seen in fluorescence angiography. Again, diabetic retinopathy, you can see microaneurysms. A laser burn has been given, photocoagulation, hemorrhages, exudates are seen. This is the classical tomato splashed appearance or tomato ketchup appearance seen in ischemic or seen in CRVO, central retinal venous occlusion. And this is the cherry red spot that happens in central retinal arteriolar occlusion. This is the cattle track sign because of the blood column which is not continuous, giving us the cattle track sign or the boxcar appearance in CRAO. Next we move on to lens. So lens, cataract, cataract is opacification of lens or the capsule. We have three types of cataract based on the lens anatomy. Nuclear cataract happens on the, this is the lens, on the nucleus of the lens. If there is any opacity at the nucleus of the lens, it is nuclear cataract, and the clinical feature is going to be emaralopia, that is day blindness, there is going to be a decreased distant vision, then we have cortical cataract that happens in the cortex of the lens. Clinical feature is going to be myopia or night blindness. It's also called as cuneiform cataract. Mainly is going to involve the cortex of the lens. The third one, which happens in the posterior subcapsule of the lens, posterior subcapsular cataract, also known as cuneiform cataract. Clinical feature, maximum visual handicap is seen here. Maximum visual loss is seen here, and have maximum glare to the light. It is a cup-shaped cataract, hence the name. Then we go for a few congenital cataracts. Zonular lamellar cataract. The most common cataract causing loss of vision in a child. Then we have a punctate or blue dot cataract. It is the most common congenital cataract in children, and there is no loss of vision. We have congenital rubella syndrome. There is a triad in congenital rubella syndrome. There is salt and pepper retinopathy. There is cataract of the nucleus, nuclear cataract, and glaucoma. Traumatic cataract or rosette cataract, since it's appear like a flower, mostly by blunt trauma, petal shaped, petal, and we have metabolic causes leading to cataract, metabolic cataract, main cause, diabetes mellitus, early senile, and true diabetic or a snowflake is the finding seen in diabetes cataract. Usually it is in early 40s. Here it is seen in young persons. It is seen in non-insulin dependent diabetes mellitus, insulin dependent diabetes mellitus. This is chronic in onset. This is acute in onset. In fact, this is the only cataract with acute in onset. Even it can happen in a night. A person can sleep with a normal vision and he can wake up in the next day morning with a cataract, with a loss of vision or clouding of vision. So that fast the diabetic cataract can develop. So diabetic cataract is also called as a overnight cataract. And then we have Wilson's disease. Yes, can anyone tell me? In Wilson's disease, what type of cataract we can get?
Sunflower cataract.
Yes, very good. Sunflower cataract. What's the protein, plasma protein that is deficient in Wilson's disease? Internal medicine.
ATP7B.
Okay. That is the gene, right? I'm asking the plasma protein.
Ceruloplasmin.
Yes, correct. Ceruloplasmin. And what is the use of the ceruloplasmin? Why our body needs ceruloplasmin? For the transport of, yes, for the transport and binding of the copper. In Wilson's disease, we have copper toxicity. Okay. Then galactosemia, what is it? What cataract?
Oil drop cataract.
Yes, correct. Very good. Oil droplet cataract. Myotonic dystrophy. Yes.
Christmas tree cataract.
Yes. Christmas tree. Cataract. Atopic dermatitis. Yes. In atopic dermatitis, we get Shield cataract. What eye sign you get in Wilson's disease? In cornea, what is it in Wilson's disease?
Kaiser Fleischer ring.
Yes. Acer, Fleischer ring due to the copper deposition in cornea. We get it is the characteristic of Wilson's disease. We also have drug-induced cataract. Steroids, chlorpromazine, chlorpromazine usually causes a stellate cataract, cataract in the shape of a star. Chloroquine, Neudarone, Sulfan, penicillamine, gold, epophthalate. And we have senile cataract, stages of senile cataract. So name says senile due to the aging of a person. We have heard that some few of our grandfather or grandmother or someone in our relative who is an old age person getting a cataract surgery done. So we'll see the stages of the senile cataract. Incipient, immature, mature, and hyper mature. So first incipient, early cataract, clinical feature, there is loss of contrast, sensitivity, there is double vision or diplopia, and there is mild loss of vision. Next to incipient we have immature, there is partial opacity or partially opaque, the transparency is lost partially, and lens looks a yellowish gray in color. Then we have a mature cataract, and there is small leakage of lens, and the water goes inside the lens. And we have hypermature cataract, the lens shrinks because of the water going inside and leading to the breakage. There is breakage. The capsule of the lens crumples. Because of this, the patient can feel the lens moving or phacodonosis. Talking movement of lens. There is dislocation of lens. There are two types of hypermature cataract. Morganian cataract. If there is a cortical cataract and that gets hypermature, the cortex liquefies because of the water and the nucleus falls into it. This is Morganian cataract, and there is another type, sclerotic cataract. There is a nuclear cataract, and that gets hypermature. There's two forms. This can end up cataracta brunescens or cataracta nigra. So the name says here nigra, so it is black color. This one is brown in color. And this cataracta nigra is the most hardest cataract because nucleus is the most hardest part of the lens, and this is the nuclear cataract. And cataracta brunescens is the second most hardest cataract. So symptoms of cataract includes slow, painless loss of vision. There is diplopia, polyopia, the treatment is going to be glasses or a surgery. So this is our posterior capsular opacification. You can see the capsule here posteriorly opacified. This is the blue dot cataract. congenital cataract, which is the most common cataract, universal, and there is no visual impairment. And this is lamellar zonular cataract or Ryder's cataract and seen in vitamin D deficiency. This is a salt and pepper retinopathy that happens in rubella, can also be seen in syphilis. This image is very important. Morgagnian cataract. This image has been asked in NEET and also in FMGE. So Morgagnian cataract. So this is the types: nuclear cataract, cortical cataract, posterior cataract, capsular cataract. You can see here the nucleus of the lens gets opacified. Here you can see the cortex mainly getting opacified. So coming to the metabolic and other types. So rosette cataract mainly happens due to the blunt trauma. We can see the shape of a petal of a flower, rosette cataract. This is snowflake cataract, overnight cataract seen in diabetes mellitus. Characteristic of type 1 more than type 2, and this snowflaking is because of the accumulation of the sorbitol. This is our sunflower cataract seen in Wilson's disease. This is polychromatic luster seen in complicated cataract. Complicated cataracts are seen in diabetic retinopathy, in retinitis pigmentosa, sometimes in myopia. A complicated cataract is nothing but it is the cataract that is happening due to a complication of other disease. So in complicated cataracts, you see polychromatic lusters. This is oil drop cataract, oil droplet cataract seen in galactosemia, and this is because of the accumulation of galactose. Here we finished some important points on ophthalm. Next we move on to ENT. Start with diseases of the external ear. Acute otitis externa, tropical ear, or swimmer's ear. We have two types: localized, also called as furunclosis, and diffuse. Furunclosis most common due to Staph aureus infection of hair follicles. Hair follicles are called as furuncle. And the diffuse type, most common cause is going to be Pseudomonas. There is severe pain and analgesics. Next we have otomycosis. Name says myco, so it is caused by a fungi. Aspergillus niger, most common, forms black colonies, and Aspergillus fumigatus, that's the green colonies. Candida albicans versus forms white colonies. Treatment is going to be oral cleaning with the help of a microsection and a topical antifungal ear drops for 4 weeks. And we have a malignant otitis externa or acute necrotizing otitis externa. Malignant is just a misnomer. It is not a cancer. It's just a misnomer. It's rapidly spreading Pseudomonas infection in a immunocompromised patient. Clinical feature is going to be pain, greenish, black, discharge, a lateral skull base, osteomyelitis, this can lead to multiple cranial nerve palsies, and the most common is going to be facial nerve palsy. The diagnostic investigation of choice is going to be bone scan, technetium 99 scan, treatment ciprofloxacin, and we go for ASOM, acute suppurative otitis media, or acute otitis media, all are same. Cause strep pneumoniae, stages, stage 1, it's a stage of occlusion of tube or tubal occlusion. The nasopharyngeal N or the cartilaginous end of the eustachian tube is blocked. This leads to decrease in pressure of the middle ear. So the tympanic membrane is pulled, retracted, leading to pain, decreased in hearing, coming to stage 2, it's a stage of pre-suppuration. There is accumulation of serous, mucoid secretion in middle ear. Here, because of the secretion, tympanic membrane bulges out, blood vessels becomes prominent, leading to the important appearance, cartwheel appearance. Stage 3 is going to be the stage of suppuration. There is going to be severe pain because of the tear. There is pus present. On examination, there is going to be a red, congested, bulging of tympanic membrane, which is ready to burst or tear. And stage 4 is the stage of resolution. It's going to be a perforation of tympanic membrane. The most common site of tympanic membrane perforation is going to be antero-inferior quadrant of pars tensa. This perforation usually heals in few weeks, and hearing becomes to normalcy. Treatment stage 1, antibiotics, analgesics, nasal decongestant drops. Stage 2, same management. Stage 3, myringotomy. This performed in the posterior inferior quadrant. In case of stage 4, just leave it alone, wait and watch. Most common complication of ASOM is going to be perforation, and the second most common complication is going to be acute mastoiditis. Acute mastoiditis, you can see ironed out mastoid. This mastoid is red, it is very hot and smooth. Battle sign. What is battle sign? Forensic. Yes, we saw in our first day.
Ecchymosis at a mastoid region.
Yes, super, very good. So, battle sign is, here it is due to the hematoma over mastoid due to fracture of middle cranial fossa. This is very important battle sign, and also Reisinger sign. This sign is also very important. There is pitting edema over the mastoid. This pitting edema is due to the sigmoid sinus thrombosis. We go for blue here or serous otitis media or secretory otitis media, all with the same synonyms. It's due to a long-standing collection of serous mucoid fluid in middle ear. There is hearing loss present, and on fluid filled in middle ear can be seen. The treatment is going to be treat the bacteria or the cause, myringotomy, and grommet insertion to drain the fluid. This grommet is inserted in anterior, inferior quadrant. And we have CSOM, chronic suppurative keratitis media. And we can have a tubo-tympanic disease or attico-antral disease. Actually, there is a perforation in the acute suppurative arteritis media that is complicating to a chronic suppurative arteritis media. This perforation, if the perforation is present in the pars tensa, if it is central of the pars tensa, it is tubo-tympanic disease, and if it is marginal, the fibrous annulus, and in case of pars flaccida, it is attico-antral disease. Tubo-tympanic disease, central perforation not involving the fibrous annulus, involving the central part of the pars tensa. There is conductive hearing loss. Ear discharge will be present. The ear discharges of mucoid or mucopurulent. It is not foul smelling. It can be continuous discharge or intermittent discharge. The treatment, antibiotics, or the discharge, and myringoplasty, the repair of the tympanic membrane, antral disease. We have something called as the polysteatoma or a keratoma. This normal keratinized stratified squamous epithelium in an abnormal place in the middle ear cleft. It can be due to a congenital condition or can be acquired. Acquired is secondary to perforation. There is migration of the squamous epithelium what do you call it? Pathology. This migration of epithelium squamous to columnar or columnar to squamous.
Metaplasia.
Yes, very good. So there is a squamous metaplasia. The clinical features, there is conductive hearing loss, and the discharge here is going to be scanty, purulent, non-mucoid, and it is going to be a foul smelling, blood stained due to bone erosion, and the management going to be modified radical mastoidectomy. The complications of CSOM is very important. Complications can be of CSOM can be intracranial, extracranial, and in extracranial it can be intra, extra temporal, can be intratemporal or extratemporal, intracranial or extracranial. In extracranial we have intratemporal or extratemporal. Intratemporal, first is going to be our ossicular chain erosion, leading to conductive hearing loss. Can be inflammation of the labyrinthus, and labyrinth fistula, the most common site for labyrinth fistula is going to be lateral semicircular canal. We have something called as fistula sign, very important, fistula sign, or fistula test. That is, on pressing of tragus with our finger, vertigo or nystagmus happens. We have something called as true positive and false negative. True positive is fistula is present, so, and fistula sign is positive. In case of a false negative, a fistula is present, but fistula sign is negative. And this false negative is seen in a dead ear, or a cholesteatoma that is covering the fistula. Important point, cholesteatoma covering the fistula produces a false negative fistula test. And false positive fistula sign is going to be seen in there is no fistula, true fistula sign is seen with, for fistula sign positive is seen in congenital syphilis and Meniere's disease, and that is called as Pennerbert's sign. Next to labyrinth fistula, we can have a retrositis. There is a long-standing discharge, and we have the syndrome, Great Nigo syndrome. There is deep pain, deep, so it is a retroorbital pain, and there is diplopia because of lateral rectus palsy. Lateral rectus is supplied by which cranial nerve? Anyone?
Third cranial nerve. Ocular
Which
motor.
one?
Third cranial nerve. Sorry, sixth cranial nerve.
Yes, please don't get confused. LR6 is SO4. So, because of abducent nerve palsy, sixth cranial nerve palsy. Then we have extra temporal complications. When the infection comes out of the temporal bone, it leads to extra temporal complications. In the temporal bone, on the mastoid process, we have two muscles attached. One is going to be sternocleidomastoid, the lateral aspect of sternocleidomastoid, and other one is the digastric posterior belly, and this is going to be on the medial aspect. So we have some named abscess, post oral or subperiosteal abscess. The name says post oral. So if the osteotoma breaks mastoid bone. The cholesteatoma breaks the mastoid bone and comes out behind the pinna, known as postoral or subperiosteal abscess. We have resolved abscess, sternocleidomastoid. If the cholesteatoma breaks the bone of the mastoid and goes along the sternocleidomastoid, it leads to Bezold's abscess. Then we have Lux or Lux abscess. If the cholesteatoma breaks the wall of external auditory canal and forms an abscess in the external auditory canal, it is called as Lux abscess. And we have zygomatic abscess. If the cholesteatoma breaks the root of zygomatic process. It's going to be zygomatic abscess in the last one. Cetalese abscess. If the cholesteatoma breaks the bone, medial to mastoid, where the posterior belly of digastric is attached. So this is Cetalese. So short recap, postural is going to be comes down behind the pinna, breaks the mastoid bone and comes one behind the pinna, postoral, subperiosteal abscess. Bezold's abscess is going to be sternocleidomastoid. Lux is going to be external auditory canal. Zygomatic is going to be zygomatic process, and Cetalese abscess is going to be the posterior belly of the digastric. And we have intracranial complications. Most common is going to be meningitis, then extradural abscess, subdural abscess, brain abscess, and otitic hydrocephalus, very rare, and sigmoid or lateral sinus thrombosis. Sigmoid or lateral sinus thrombosis is going to be very important. Clinical feature, it is also called as piquant fence fever or remittent fever, because the fever rises and then it goes down, but it never comes to normal. It keeps, the temperature keeps fluctuating. It goes up, goes down, but it never comes to normal. And rice finger sign already we learned is the edema over the mastoid. OB higher test is the rise in intracranial pressure when the internal jugular vein is pressed over the normal side, and we also have the Probeck test. Whenever the internal jugular vein is pressed on the normal side, there is engorgement of retinal veins. And the CT, MRI, CT finding, MRI finding is a very important radiology question. Important radiology question. MT delta sign. It's the most important sign seen in sigmoid sinus thrombosis. So here we finish the complications of CSOM. Next we go for protosclerosis. Most common site, fistula anti-fenestrum. It is present just anterior to the whole window. That leads to the fixation of the stapes bone. Presentation is important. Most commonly seen with females. Close to 1 ratio, 20 to 30 years. And this incidence to get autosclerosis get increased with pregnancy. We have the Schwartz sign, most important ENT question. Schwartz sign we have. This has been asked many times in exam. Flamingo, pink colored tympanic membrane. Seen in early or active phase of disease, also known as the phase of otospongiosis. And in pure tone audiometry, we will get a dip in bone conduction at 2000 hertz, known as the cohorts notch. This is also a very important question. This has been asked in exams multiple times. The treatment for otosclerosis is going to be a laser stepidotomy. Then we have Glamorous tumor. Most common benign tumor of middle ear, age 40 to 50 years. This is also most common in females. Female is to male ratio about 5:1. This tumor arises from the paraganglionic cells the glomus body. Glomus tumor can be divided into two types. Glomus tympanicum, glomus jugular. This is arising from the paraganglionic cell, which are on the promontory along the course of Jacobson's nerve. Jacobson's nerve is a branch of Which cranial nerve? Yes, anyone?
Facial cranial nerve.
Which one?
Facial, seventh nerve.
No, not seventh. Any other try? The branch of ninth cranial nerve. The glossopharyngeal. It is limited to middle ear only, and this causes palsy of seventh cranial nerve or the facial nerve. Whereas glomus jugulare arises from dome of jugular. It involves the jugular foramen. It spreads to skull base, can cause multiple cranial nerve palsy, 9, 10, 11 cranial nerve, and this is called as this involvement and leading to the paralysis of 9, 10, 11 cranial nerve is called as the jugular foramen syndrome or Werner's syndrome. And the clinical feature is going to be for both of them is going to be there's a conductive hearing loss and pulsatile tinnitus. On examination, we can see a profusely bleeding growth or a polyp. Signs: rising sun sign, and we have Aquino sign. If the jugular vein is rust, tinnitus will be improved. When we have brown sign and using a seagull or a seagullization, tumor blanches and changes the color to white. Investigation of choice is going to be contrast enhanced CT. Then we have Phelps sign. There is inability to distinguish between internal carotid artery and the jugular bulb due to the erosion of carotico-jugular crust. We have the famous rule of 10% for Glamorous tumor. Usually they are 10%. Multicentric, they are 10% hereditary or familial, 10% only secretory, secretes catecholamines. Since the paraganglionic cells are supplied by the sympathetic nervous system, the treatment is going to be surgical excision. And we have Meniere's disease, also known as endolymphatic eye drops. It is the disease of cochlea, endolymphatic eye drops. So the name, we have endolymph. It accumulates inside the cochlea. We have endolymph and ectolymph in the inner ear. So this endolymph accumulates inside the cochlea, leading to the bulging of Reisner's membrane present on the inner ear. This can lead to bursting, and there can be mixing of endolymph with the ecto or the perilymph. Presentation is going to be, it is a unilateral disease, male more than female, M, Meniere's M. So males, remember like that, 35 to 40 years, male. And the triad of Meniere's is going to be, there is going to be a episodic vertigo, fluctuating sensory neural hearing loss, and tinnitus. We have Julio phenomena, loud noise, precipitate, vertigo, loud noise precipitates a vertigo, and then we have Lermoyer's syndrome. It is a variant of Meniere's disease. And here vertigo, relieves the sensorineural hearing loss, and Morkin crisis, sudden fall on ground because of increased severity or severe Meniere's disease. Investigation is going to be a Glycerol test. Glycerol is an hydroscopic agent, so it will absorb the fluid or the water, and that will lead to a increase in about 10 decibels of the sensory neural hearing loss on the pure tone audiometry. So this is Glycerol test. It's done usually in a acute attack of Meniere's disease. Gold standard investigation is going to be electrocochleography. The management is going to be medical with the help of diuretics, beta blockers, histamines, decrease tea, coffee consumption, decrease salt in diet, surgical, conservation surgery. We can go for the endolymphatic sac decompression, and the radical surgery is surgical labyrinthectomy, gold standard is going to be surgical labyrinthectomy. But nowadays, new treatment options are available. Before going from medical to the surgical, we can try the intratympanic gentamicin therapy. This gentamicin is an antibiotic of which class? Can anyone tell me? Gentamicin is an aminoglycosides, and they are toxic to inner ear, ototoxic. We have gentamicin, amikacin, kanamycin, natamycin, all those mycins. Most of the drugs are ototoxic. So also we have Meniere's device. It is a new home-based treatment. This device will decrease the pain or the tinnitus in the Meniere's disease used in USA, not in available in India. This FDA approved device. And we have vestibular schwannoma, most common tumor of cerebellopontine angle, most common site of origin, Schwann cells of inferior vestibular nerve, symptoms unilateral, slow, progressive sensory neural hearing loss, and there is tinnitus. Hitzel-Berger synosine, involvement of seventh cranial nerve, where the sensory supply to postero superior wall of external auditory canal is lost. Investigation of choice is going to be a contrast enhanced MRI. The contrast used here is gadolinium. In radiology, the names of contrast agents used can be asked. So please memorize the names of contrast agents used and which all diseases in liver condition which can be used, which cannot be used, in renal failure which can be used, which cannot be used. They can ask like that. Treatment is going to be surgical excision. And here we conclude, leaving the rest to you guys. Thank you for listening patiently. Thank you.